And now I call upon Dr. Anju on OCT in retinal pathology, what a general ophthalmologist should know.
So, good morning to one and all present here. So, I am going to talk about OCT, what a general ophthalmologist should know. So, basically, I'll be discussing with all these topics. And all these topics, first is introduction. So, it is a non-invasive, non-contact transpupillary imaging system which provides high-resolution cross-sectional image. Is used as a principle of low coherence interferometry. So, next is scanning protocol. So I'm not going into detail of all of this. So we use time domains, which is an old one, which cannot picture 3D images. Next is frequency domains, web source. Commonly used one is spectralis OCT, which was introduced in 2006 based on HRA2. It has incorporated two imaging techniques, that is confocal scanning laser ophthalmoscopy, which is commonly used for octa and autofluorescence. Next is confocal imaging creates transversal image of the retina corresponding to on-force phase of OCT. It utilizes infrared CSLO scans for automatic motion tracking. So next I'll be going into the detail of OCT scan protocols, in which macular scan, thickness scan will be dealt in detail. So these, as we all know, these are the layers of the retinal layers seen in OCT macula. We'll be going in detail with this. So first one is line scan ophthalmoscope. In this only the thickness is measured. Next is ETDRS. In ETDRS, we'll be measuring the thickness from the ILM to the RP. It consists of three circles, outer, inner and innermost circles. Next one is cross hairline image, which shows a black and white or color-coded images, which represents the macula taken from the horizontal direction from the temporal to the nasal. So next is raster scan, which is a selective scanning profile. It's usually taken at the angle of 30 degrees. So first question, when we see an OCT, we have to find out which eye is this. So how do we know which eye is this? So this is an OCT image of right eye. How do we know that? Because of the thick RNFL hyperreflective band exiting through the retina through the ONH. So next is OCT analysis and interpretation. So we have to know the basic international nomenclature for OCT. We use these terminologies. First is band, which shows the 3D structure of the retinal layers anatomically. Next is zones, region on OCT whose anatomical correlation was not clearly delineated. Next is RP-Brux membrane complex, one of the layers described as zone, as they are inseparable owing to the interdigitation of the cellular structure or tissue. So next is going into the interpretation. It is normal OCT interpretation with all these layers. First is pre-retina. Is a vitreous anterior to the retina, non-reflective dark spot on the OCT. We can see faint dots as noise formed due to electronic aberrations. Next is vitreoretinal interface. Is well defined due to the contrast between the non-reflective vitreous and the backscattering of retina. The contents vitreous overlying the ILM is called as a posterior vitreous phase. Next is epiretina. Epiretina is anterior surface of the retina, in which commonly seen as epiretinal membrane. Next we are going into the retina proper. This is anterior boundary from the hyperreflective band of ILM to the bounded posteriorly by the RP layer. Next we have one more entity called as outer retina, which is very commonly used nowadays, which consists of an ELM layer, ISOS junction, RP-Brux membrane with myoid zone, ellipsoid zone and interdigitation zones. Next is choroid. Choroid is commonly seen within EDI OCT. So next is what is the foveal cut we see. So foveal cut is the area where the outer plexiform and the RNFL meets. So we'll be dealing this OCT into a qualitative analysis and a quantitative analysis. Based on the qualitative analysis, first is morphological study, in which we'll be seeing the overlying retinal changes with retinal outline. In this, we'll be dealing with the major regions, that is pre-retinal area, epiretinal, intraretinal and subretinal. So next is the reflectivity studies. Based on these terminologies only, we interpret the OCT, like hyperreflective, which appears as a white in color, hypo is dark in color, and next is shadowing. So these are the pictures showing hyperreflective dots here, hyporeflective cavitatory lesions here. This is a shadowing and this is reverse shadowing. So these are the common reflective structures. You can take a picture if you want. So these are the abnormal pathology. If we know the normal reflective structures only, we will be able to find out which are the abnormal reflective structures. So this is high reflective structures in each layers, and this is medium reflective structures and low reflective structures, that is hyporeflective structures. So next is a shadowing. In this also we'll be seeing superficial shadowing, interretinal shadowing, deep shadowing, each and everything. So next we'll be dealing with the quantitative analysis. In this quantitative analysis only we'll be dealing with the retinal thickness, based on which we will be seeing whether the treatment has to be given for the diabetic retinopathy based on the study grid, and we will be depicting the thickness based on it. So next is the retinal maps. In this color maps are used. For each and every layer a single color is used. So when you got an OCT, we have found out which protocol it is used, which eye we have identified. So now what do we do? So first determine the scan quality. Next, rate the overall scan picture profile and evaluate the foveal profile. Next, identify the foveal cut and carry out the structural assessment. Structural assessment will be each and every structure, like from pre-retina to the epiretina. So these are the common terminologies used. I am not going into the detail of this. So next is clinical cases. So first is vitreous and vitreomacular interface pathology. This is a vitreous hemorrhage. We will be seeing a subhyaloid hemorrhage. In OCT, we will be seeing as a shadowing of the inner layers from the hemorrhage with the PVD. Next is asteroid hyalosis seen in a B scan, with seen in a multiple hyperreflective spots seen in the vitreous cavity. Next is vitreous cells seen as dot-like hyperreflective materials. Next is PVD. This is the first one, thin hyperreflective layer. Next will be CMV with PVD VMT. Next is complete PVD. This is epiretinal membrane seen as a corrugated surface adherent to the ILM. Next is vitreomacular traction. First is VMA within the 3 mm of the radial fovea. Next is the VMT. In VMA, there will not be any retinal morphological changes. In VMT, there will be retinal morphological changes. Next will be full thickness macular hole. So next is intraretinal. I'll run with this. And first one is macular edema. Second is the stages of macular holes. And in hard exudates, we will be seeing hyperreflective spots with back shadowing. That is how we identify it as hard exudate. Next is cotton wool spot corresponding with hyperreflective layers. Next is intraretinal hemorrhages. This is retinal degeneration. The next is inner and outer retinal atrophies, retinoschisis, HCQ toxicity, early photoreceptor and outer retinal damage with a spaceship sign. Next is subretinal, is ARMD, drosenoid PEDs, wet ARMD showing intraretinal edema, exudates and subretinal hemorrhages with SRF, global geographic atrophy, CSR, PEDs with drusen's, serous PED and fibrovascular PED. In fibrovascular PED, we will have to go with an octa. Neovascularization showing intraretinal fluid, subretinal fluid and tractional membrane. The outer retinal tubulations, retinal detachment. So these are the common newer findings which is discussed. You can take a picture if you want. These are advantages. Non-invasive, non-contact, more repeatable for the patient. So limitations are in there is media opacities and artifacts. So I'm winding up with my session with this. Thank you.
Thank you, Dr. Anju, for that quick rundown on